Hi, welcome back. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with another full-length radiology lecture that I've recorded. And just like the others, the purpose of these is just to have some educational content that we can share with the trainees, the residents, the fellows, the medical students. Right now, as we have trainees that are potentially in quarantine or being furloughed, as we're sort of adjusting to the new reality of what's going on with this escalating COVID crisis. So just wanting to do my part, put some educational content out there to share freely among people who are interested in it. Hope everybody's doing well, staying healthy, staying sane. This topic for today's talk is going to focus on the infrahyoid neck. And it's sort of going to be a differential diagnosis-based lecture. So we'll run through the different contents, the different spaces in the infrahyoid neck, or at least the main ones, and talk about some of the different structures and some of the pathologies that can occur here. So I have no disclosures to make. Wish I had some financial disclosures, but alas, I do not. I would like to acknowledge several people who were kind enough to share some content with me for this talk. First and foremost, Rick Wiggins and Rick Harnsberger, both of whom over the years have shared a lot of education and learning with me, but have also provided some of the graphics, as well as a couple of the cases that you'll find in this presentation. So thanks to both Rick and Rick for the kindness in sharing these over the years. I'd also like to thank Jim Milburn and Todd Cum, both of whom provided some additional content for this lecture as well, and you'll see that here in a few minutes. So again, lots of parties. Can't take credit for everything that you're seeing here in this talk, but in the spirit of sharing this, I do want to thank them for everything that they've done to help out with this as well. Okay, so let's get started. The infrahyoid neck covers a lot of ground. There are a lot of different spaces that are involved, each of which contain multiple anatomic structures, and for that reason, there's really a lot of pathology that can occur here. In fact, the thing that I think is most challenging, but at the same time most interesting about the infrahyoid neck is just the diversity of pathologies that can occur here. So one of the key things, really maybe the most important thing to take home from this talk is whenever you're approaching a generic lesion, a generic mass, you name it, whatever it is that you encounter in the neck, try to figure out where it's coming from. What is the space of origin where it's arising from? Because if you can do that, that's immediately going to narrow down your differential diagnosis. Another thing to keep in mind, if you see something that is extending between multiple spaces, or if it's multispatial or transspatial, think about congenital etiologies as well as aggressive etiologies, things like infection or malignancy, because those are the types of things that tend to cross those spatial boundaries. Okay, so that was sort of the very brief introduction, and there's a lot of content to cover here, so I'm just going to dig right in. So first, we're going to be talking about a space-based differential diagnoses and run through some common and uncommon things that we encounter in the visceral space. Now, as you look at the visceral space, as you can see here, there's a lot of contents within it, and each of these will have different pathologies that can occur. So I'm not going to talk specifically about the larynx, and I'm really only barely going to dabble into the hypopharynx. Those two are sort of an entity into themselves, and it's sort of a separate talk that would cover all of the many things that can happen here. So we're not going to talk about those, but instead we're going to start with the trachea. And the trachea is something that I think that head and neck radiologists tend not to embrace anywhere near the same way that chest radiologists do. And I think that that's something that we really need to be thinking about and having at least a basic understanding of some of the pathologies that can occur here. So the first thing to talk about is tracheal stenosis, and that's because it's such a common indication for imaging. These patients will often present with dyspnea, and I think that when I approach one of these cases, some of the key things that I want to think about is, am I dealing with a child or an adult? Because with a child, you're thinking more commonly anyway of congenital things. An adult, much more common to be dealing with acquired etiologies. Critically, has the patient had prior surgery? Have they had a prior intubation? Was it a prolonged intubation or a traumatic intubation? When I look at it, is this a short segment? Is it very focal, or is it a long segment process? And then importantly, things to report would be, how narrow does it get? What's the narrowest diameter? Because that's something that the surgeons, that the pulmonologists may want to know about. And when you're dealing with a lesion, a mass, you want to try to decipher, am I dealing with endoluminal obstruction, something that's contained within the trachea itself, or is this extrinsic compression, something on the outside smashing it down? And then when you look at it, you want to look and see, does it look like some sort of a smooth contoured thing, or is it something that looks ratty and aggressive? So when we're dealing with acquired tracheal or subglottic stenosis, as you can see on the slide, there are a lot of intrinsic causes, but far and away the most common intrinsic cause of stenosis that I see relates to prior intubation and prior tracheostomy. But there's a lot of things, and we'll talk about some of them during the talk. As far as extrinsic causes, in my experience here in my shop, the thing that I see most commonly are thyroid lesions, thyroid masses, whether it's a goiter or a true malignancy, that are externally compressing it. But again, you can see here there are lots of potential extrinsic causes of tracheal stenosis as well. So this is an example of a tracheostomy-related tracheal stenosis. You can see where that yellow arrow is pointing. That's just right sort of at and maybe slightly below the level of where the, right at and above the level of where the tracheostomy is entering at. And you can see just how narrow that tracheal diameter is. Now compare to the more normal distal downstream caliber, and you can see that's a really significant difference between those two. Now, you may say, well, it doesn't really matter. He's got a tracheostomy tube in. And in fact, you're right. They're protecting the airway now. But let's say they want to get to the point where they're going to take that tracheostomy out. They need to know about that stenosis, because this is a patient that's going to get themselves into trouble because of that very tight stenosis related to the prior tracheostomy. This is another patient. This is a patient who had previously had a prolonged intubation. And you can see that they have a very focal area where you have sort of a shouldering, a narrowing of the trachea, probably related to that prior prolonged intubation. So again, you want to find it, you want to identify it, look for sort of that hourglass configuration in which you, in this case, have a very focal waist or very focal narrowing, and report that. Tell the surgeons, tell the pulmonologist how long it extends over and what the sort of the nadir of the narrowing is. Next would be malignant tracheal masses. Now, fortunately, primary tracheal tumors are quite rare. We're talking literally something that's about a 1 in a million diagnosis. And of these, squamous cell carcinoma is going to be the most common culprit, followed by adenoid cystic carcinoma. Now, the imaging is quite limited in terms of trying to predict what the final histopathology is, and that's okay. These patients are going to need an endoluminal biopsy to figure it out. That's not your job. So I can't look at the imaging and say, oh, this is clearly a squam or this is an adenoid cystic. You can play the odds and say that squam is more likely. But instead, as the radiologist, your job is to look for invasion of surrounding structures. Look for invasion of those other visceral space structures that are in close proximity. So this is a patient who had tracheal squamous cell carcinoma. As you can see, there's a mass on the left side, and it's denoted here by the yellow arrow. And it's ugly, it's aggressive. You can see it's really markedly narrowing the airway. But if you look at the coronal image, you can see, importantly, it does look like it's extending out into the surrounding soft tissues and probably starting to invade the thyroid itself. There's nothing that I can say on this imaging that will tell me that this is certainly a squamous cell carcinoma. That just happens to be the most likely diagnosis based on the statistics. Here's another patient with a malignant tracheal mass. This was an adenoid cystic carcinoma. Again, I can't look at this and tell you that's what the diagnosis is. That's okay. That's what the biopsy tells you. But rather, what I can do is look at this and describe where the tumor is going. How big is the tumor? And in this case, this is a nice example of how CT and MRI can be complementary in staging disease. We can tell on the CT, yeah, it looks like tumor's getting out of the trachea. MRI is much more specific in terms of telling us where it's going. We get that tissue contrast resolution superiority that helps us to better stage where the tumor is at. Next diagnosis is relapsing polychondritis. This is a rare diagnosis, and it's an autoimmune disorder in which patients have recurrent cartilage inflammation, and eventually, most commonly, it leads to cartilaginous destruction. It can be a very focal process, or it can be a very diffuse process. It can affect multiple different cartilages within the body, and certainly the trachea is one of those structures that contains cartilaginous rings, so it can be involved. Now, classically, this involves the anterior and lateral tracheal walls, or even the airway walls. You can use the same application down once you get below the clavicles into the chest, but it has sparing of that posterior tracheal membrane, or the posterior airway membrane, because that's a non-cartilaginous structure. So as we look at this case, we can see sort of that thickening and a little bit of irregularity of the walls of the trachea, anteriorly and laterally. But if you look carefully, you can see that this spares that posterior wall, or that posterior tracheal membrane. Over time, the classic trajectory of this is to lead to cartilage collapse, and you can get really severe airway narrowing as a result of this. Now, sometimes, and this is quite rare, sometimes you can actually get enlargement of the cartilaginous structures due to that sort of chronic, repetitive chondral inflammation. And this is such a case of that. This is an atypical appearance of relapsing polychondritis. And what should really jump out at you is, you can see the image on the left on the axial CT. Look how thickened that thyroid cartilage is. Image on the right, look at this cricoid cartilage, just how thick and knobby this is. It's not getting destroyed, but it's markedly enlarged. Don't burn this into your mind as the typical appearance, because more typically we'll see cartilaginous destruction over time. This happens to be one of those really oddball cases that resulted in cartilaginous enlargement. Importantly, really the critical thing here is when you have that cartilage getting that enlarged, it can compromise the airway. So always be on the lookout for airway narrowing, always be reporting that. Something that can look a little bit like this is amyloidosis. And this is a rare disorder. It's of abnormal protein folding, and it can be primary or secondary, or localized or diffuse. And when it involves the airway, it's more commonly going to be the localized variety that specifically is just involving the airway, but you can have sort of the diffuse involvement or even secondary amyloidosis resulting in airway disease as well. But this occurs when you get deposition of the amyloid fibril proteins into otherwise normal tissues. And so it can be very diffuse, it can be multifocal, but importantly, it can involve the posterior wall of the trachea and the posterior wall of the airways, the smaller airways in the lung as well. So that's sort of in contradistinction to what we saw with relapsing polychondritis. And it gives you these submucosal masses. So here we see sort of that heaped up soft tissue along the posterior tracheal membrane on this axial non-contrast CT imaging. As you can see right where that arrow is pointing, it's associated with some calcification as well. So these submucosal masses can be calcified. If you do MRI, they have a characteristic dark T2 signal, so they're hypointense on T2. That's an important thing to keep in mind. If you give contrast on MRI, you may have enhancement as well. This is another patient who had tracheal amyloidosis. This is path proven, and you can see that this is, instead of being more of a sort of a smooth, diffuse, infiltrating soft tissue, this is sort of a multinodular appearance. But as you look, this is involving sort of the posterior and posterolateral walls of the cervical trachea, and it's multifocal, sort of heaped up submucosal masses. And you can see, if you look carefully, there's a little bit of calcification associated with this as well. So the calcification doesn't give you a ton of specificity, but it is an important finding to be looking for and recognize that tracheal amyloidosis can, in fact, have calcification. Now, interestingly, it's something that if you do FDG PET, you may also see some hypermetabolism with it, so therefore it can potentially mimic malignancy as well. So sort of keep that in mind, that tracheal amyloidosis can be a bit of a diagnosis that acts as a mimic and can cause some consternation. Next, we have granulomatosis with polyangiitis, and this is an autoimmune necrotizing granulomatous vasculitis. And these patients will have anti-neutrophil cytoplasmic antibodies, or ANCA. And we always think of it in the head and neck world as being a sinonasal process, and it is. I mean, that's the most common presentation, but it can involve any of the airways, and the trachea is no exception. These patients will get cartilaginous erosion. They can even have like these mass-like soft tissue thickened areas along the airways. So here As you can see on the left side of the proximal cervical trachea, we see sort of that heaped up in what was an enhancing soft tissue component, has a little bit of ulceration within it as well. If I saw this, I would have to lead with malignancy. I mean, you have to bring that up as a potential here, and this is going to need biopsied to discern the difference. Now, it's a case in point where you want to look at other imaging. If they have sinonasal involvement, certainly be thinking about granulomatosis with polyangiitis, but it certainly can mimic malignancy as well, and that's something that you need to consider. Next is something that's benign and something that we see quite commonly. This is a tracheal diverticulum. This is simply mucosal herniation through a defect in the tracheal wall. You can see right here we sort of have this air density structure sitting to the right side of the trachea. These are usually incidental findings. They usually are quite small. They're single. Sometimes, though, they can have sort of a larger multilocular appearance like this one. I showed this just because it's such a nice example to drive home the point of what they look like, perhaps a little bit more exaggerated than we typically see. And these are usually on the right side. I have not a clue why, but you'll find that, yes, you can have them bilaterally. Yes, you can have them on the left side, but most commonly you'll see it on the right side. One thing that I do think is an important discriminator is look for an air fluid level. These should not have an air fluid level. I repeat, these should not have an air fluid level. If you see an air fluid level, be thinking about esophageal diverticula. And that is sort of my segue into discussing the esophagus. So we're going to start with the bad boy, esophageal carcinoma. And you probably don't need me to tell you this if you've done radiology for any time at all, but cross-sectional imaging is not great for evaluating for esophageal carcinoma. It just simply isn't. This is a diagnosis that really we rely most heavily on endoscopy in this day and age. Certainly, esophograms are useful. You can pick them up on esophograms. In this case, you can see sort of that classic apple core appearance. And so, yes, be able to recognize these on esophograms. They're oftentimes much more subtle than what I'm showing here in this example. But in general, while you can see it on cross-sectional imaging, it's not our best modality for looking. What you may see on the cross-sectional studies like CT would be thickening of the wall of the esophagus, oftentimes looking a bit smudgy or ill-defined. But really, where I think the important role is for those of us doing CT imaging is to look for things that upstage your disease. You're looking for invasion of surrounding structures in the visceral space, as well as looking for metastatic adenopathy. So, just to show you how challenging it can be on CT imaging, here we see this relatively short segment of the distal cervical esophagus, in which the wall is just a little bit thickened, just a little bit smudgy. Obviously much easier to see on this FDG PET, where you can see that it's markedly hypermetabolic. This was path-proven esophageal carcinoma. I mentioned esophageal diverticula before. Now we're going to talk a little bit more in depth about them. You can have true diverticuli, which contain all of the layers of the wall, or you can have false diverticuli, or pseudo-diverticulum. And that contains the mucosa and the submucosa that herniates through a defect in the muscularis layer. So a true diverticulum has all of those layers. The false diverticulum lacks the muscularis because the mucosa and submucosa herniate through it. And the things that we oftentimes refer to as esophageal diverticuli, such as Zinker diverticula or a Killian-Jamieson, those are actually pseudo-diverticuli. You can also classify esophageal diverticula as being traction or pulsion, with the traction diverticulum due to extrinsic pulling on the wall of the esophagus, and a pulsion diverticulum is due to intraluminal pushing causing that protrusion. I said I wasn't going to talk about the hypopharynx. That's a slight lie that I told you. I am going to talk about the hypopharynx here, but sort of lump it under the esophagus, just because these are such closely related entities. And so we'll talk about hypopharyngeal diverticulum. And this goes by the eponym of a Zinker diverticulum. This is technically a Pulsion pseudo-diverticulum, in which you have mucosa that herniates above the level of the cricopharyngeus muscle, usually at about C5, C6. So you can see here in this diagram, we've got our yellow arrow pointing at this Zinker or hypopharyngeal diverticulum, where it's herniating out through a defect just above the cricopharyngeus. And this is associated with esophageal dysmotility. Typically, it's going to involve the midline posterior wall of the esophagus, but it may extend off to the left side, or more commonly to the left side when they get larger. But again, I want to stress the importance. Look for that air fluid level. That really should help you to recognize that you're dealing with something that's containing contents of the gut or the digestive tract. And these are associated with dysphagia as well as an increased risk of aspiration. So here's an example on an oblique barium esophagram. You can see that fluid and barium and gas contained within this hypopharyngeal diverticulum. You can sort of see that slip down at the bottom of it. That is sort of the imprint at the level of the cricopharyngeus muscle. But then on the cross-sectional, the axial CT that we're looking here, you can see that really large Zinker diverticulum containing an air fluid level, denoted again by the yellow arrow. Now these are different than Killian-Jamieson diverticuli. Killian-Jamieson diverticulum is also a Poljan pseudodiverticulum. But this occurs below the level of the cricopharyngeus. So this is a herniation that protrudes out into what's called the Killian-Jamieson space. And I honest to God, I hate eponyms. I could not find a good non-eponymous term to use for a Killian-Jamieson diverticulum or this space. But it is important, especially for the residents out there, to recognize what sort of makes up this Killian-Jamieson space. And it's defined superiorly by the cricopharyngeus muscle. So that's going to be sort of the superior border of it. Anteriorly, it's going to be made up of the cricoid cartilage. And then it's a triangle. So the third side is going to be the esophageal suspensory ligament, which sort of sits inframedially. These more commonly occur on the left side than on the right side. And these protrusions kind of pooch out along the anterolateral wall of the esophagus rather than the posterior midline wall like the Zinker or the hypopharyngeal diverticulum. But again, look for the air fluid level. I think that's a helpful feature to tell you you're dealing with gut contents. And then these patients are oftentimes asymptomatic, so this is frequently more of an incidental finding than a Zinker diverticulum. You can also have lateral esophageal diverticuli. And these are not exactly the same as the Killian-Jamieson because they don't come out through the true Killian-Jamieson space, but you can have them occur really anywhere along the course of the esophagus. And here you can see one on this barium esophagram. It's partially opacified. Same patient, just to sort of give you the coronal CT correlate. We can see this really large diverticulum pooching out of the right lateral side of the esophagus, and you can see that debris contained within it. The next important anatomic structure that lives in the visceral space is the recurrent laryngeal nerve. And this sort of warrants a little bit of a sidebar discussion. So where does it live within the visceral space? Well, it lives within the tracheoesophageal groove bilaterally. So here, these white arrows are pointing at the recurrent laryngeal nerves. And it's important to know the course of the recurrent laryngeal nerve. So this is sort of a branch off of the vagus nerve. And in this diagram, we're looking sort of from the back, looking forward. And we know that we're looking from the back forward because you can see the thyroid with the parathyroid, the 4 parathyroid glands. So we know we're looking at the back side of things. So what's on the image on the left, the right side of the image corresponds with the patient's right side, sort of by radiology definitions here. So the bottom line is follow along the branches of the vagus nerve. So you're going to work your way down the carotid space. On the left side, here denoted by the white arrow, image left, patient's true left, because again, we're looking from the back, you need to look all the way down to the aortopulmonary window, which is where that branch comes off, and then it's going to work its way back north in the tracheoesophageal groove. On the patient's right side, here shown on image right, you can see that it loops under the subclavian artery before recurring up that tracheoesophageal groove. And the critically important thing to know about the recurrent laryngeal nerve is that it innervates the intrinsic muscles of the larynx with the exception of the cricothyroid. So, as we look here, the question is which side is abnormal? We have an axial fused FDG PET CT. So let's run through the imaging findings. we've got marked increased metabolism here within the right true vocal fold. We've got our cricoarytenoid here, also shows FDG uptake. So is the right side abnormal or is the left side? Well, look at the left side. Here's our true vocal fold. Really no metabolic activity, and this is a muscle, okay? So there should be some metabolic activity here. We also have sort of an atrophic look to the cricoarytenoid back here, which is also not showing any FDG uptake. If you look carefully through this, I know it's tough with the fused image, but you can see that it's a little bit fatty replaced. And we also have dilatation of the ipsilateral laryngeal ventricle, giving us that classic Spinnaker sail sign. And so that tells us that the problem here is on the patient's left side. Follow the course of the recurrent laryngeal nerve. We can see this nodal conglomerate. So this patient has left-sided vocal cord paralysis from metastases, nodal metastases that are encroaching upon the left recurrent laryngeal nerve. All right, next we're going to move on and talk about the thyroid gland. And this is probably the biggest portion of this talk because there is just so much that happens here and so much to say. But just as a very brief overview, the thyroid gland is an endocrine organ. It has two lobes that are connected at midline via an isthmus. Sometimes patients will have a midline pyramidal lobe as well. Now, in terms of imaging, really our first-line modality is ultrasound because that is our most sensitive sequence. It really images it better than anything else. Plus, you can sort of marry that with a needle, and there you have your answer if you really need to figure out what something is. You can use an ultrasound and guide a needle into it and take a biopsy. So really ultrasound up front, that's our first line modality here. CT is important. You may do it with contrast, you may do it without in some circumstances because of iodine load considerations when you're dealing with differentiated thyroid carcinoma. It's a bit controversial, it remains a bit controversial, but oftentimes we are wanting to minimize the amount of iodine that patients with differentiated thyroid carcinoma get because that will sort of drive down the body's resorption of iodine. And when you go to treat them with radioiodine, you want them to be iodine starved and taking up every last bit of that radioiodine. So when you're dealing with differentiated thyroid carcinoma, that is a consideration you have to make. We do use MRI. Really, I feel like pretty frequently anymore, looking at the thyroid in patients with differentiated thyroid carcinoma, particularly those who have iodine considerations. And then nuclear medicine also plays a very, very important role here. As you can see, there are lots of agents, I-123, I-139, Tec-99M pertechnetate, as well as FDG, and more recently, DOTA. Okay, so let's talk a little bit about thyroid pathology. Well, here's the good news. Most of the times when you encounter a nodule in the thyroid, it's going to be benign. In fact, the vast majority, like maybe on the order of 95% of the time. Other good news, it's a pretty superficial organ, and therefore it's easily biopsied with ultrasound. And in general, when you have cancer of the thyroid gland, most of the time, not all of the time, but most of the time it's treatable, very treatable cancer, at least relative to other types of malignancy. These are cancers that patients may very well die with rather than die of. Again, that's not a universal statement. There are certainly some bad things that occur here. But in general, of the cancers, thyroid is one of the more treatable ones. However, there is bad news, and that is to say, whenever thyroid cancer is ugly, it's really, really ugly. So as I mentioned, ultrasound is really our first line modality. Now here's the problem. I'm a head and neck radiologist, and I know very few head and neck radiologists out there that just love to deal with thyroid ultrasounds, right? For some reason, this is something that in most shops is really sort of under the purview of the body imagers. And I think most head and neck radiologists are kind of okay with that. So here's a meme that my friend Todd Combs sent me, and I think this really totally hits the nail on the head. Like, yes, the thyroid is a head and neck structure. Yes, the metastases go in the head and neck. For some reason, head and neck radiologists are like go into complete freak out mode if they have to deal with a thyroid ultrasound, and I'm as guilty as anybody else with that. So maybe we do need to know a little bit more about it. And so I'm going to do just sort of a quick overview of some of the high points of thyroid ultrasound. I'm certainly not an expert. I'm not pretending to be able to make anybody an expert on thyroid ultrasound during this brief talk, but there are some important points that I think head and neck imagers need to be aware of. Okay, so first up, let's talk about reporting thyroid ultrasounds, because this is an area where I think that there's actually some really nice guidance that can be found and you can have right at your fingertips. And the first is the Thyroid Imaging Reporting and Data System, or TI-RADS, which comes from the ACR, the American College of Radiology. And I'd like this because it's a really nice, concise risk stratification and biopsy tool. It's a paradigm, really. And so the things that you need to look at sort of have to do with the composition of the nodule. What does it look like on ultrasound in terms of its echogenicity, its shape? What do the margins look like? Whether it has any internal echogenic foci, as well as the size of the nodule. And so really, it's a bit analogous to BI-RADS that the breast imagers use. A lot of the same sort of sonographic features, I think, are a translational skill set. It's not exactly parallel, but the same kind of lessons that we can learn from mammographers and breast imagers. I like to tell the trainees, take things that you learned while on mammo and apply it to the head and neck, because I really think that they, as a subspecialty, have figured out how to really use data, good data, to drive clinical practice, and so that's what TI-RADS attempts to. Now, I'm not going to go through this whole flowchart. You can find this in the TI-RADS reference that I had on the last slide. But basically, you look at each of those categories and you do some scoring and you add up your aggregate score, and that tells you sort of your triage risk assessment of a thyroid nodule and whether or not it needs to go to biopsy for further evaluation and management. Another paradigm which is broadly used is the American Thyroid Association, or ATA paradigm. And this is also for risk stratification and trying to figure out management and biopsy needs. And this relies more on specific imaging patterns, as well as the size of lesions as well. So I think for all the residents out there, you probably have seen this 1,000 times, right? This is in every body reading room. You can see this. Usually it's posted on the wall or in cubicles. And these are just sort of the standard issue imaging appearance of different thyroid nodules. And if you look at the bottom of the image, you can see, the benign appearance. And as you work your way up to the top, these are imaging patterns on ultrasound that confer a greater risk of malignancy. So while I think TI-RADS is a little bit more simplified, and this may be a little bit more at your discretion in terms of how you interpret the images, the thing that ATA makes really nice is it has a great decision tree that's built into it. And based upon all of these different variables and how highly suspicious the ultrasound pattern is, it really is a nice way to plug in and sort of just work through the system and figure out what the next appropriate step is. So I won't, again, go through this entirety of the spreadsheet or this flow sheet. Just be aware of it and check out the ATA's guidelines and make sure that you sort of have an understanding of how to use them. Okay, so let's talk about some specific thyroid pathologies. First up is a thyroid adenoma. So you can have true adenomas that have a defined capsule on histopathology, or you can have adenomatous hyperplasia that has an incomplete capsule. I still tend to lump these together and think about them in the same way. But what do they look like on imaging? Well, unfortunately, it's a whole lot of non-specific stuff. So on CT, the enhancement pattern can be variable. They may or may not have calcification. They may or may not contain hemorrhage. On MRI, same boat. Variable signal intensity, variable enhancement. This is an area where I think ultrasound is much more helpful. On ultrasound, the majority of them tend to be solid and homogeneous. Usually they're sort of on the iso to hyperechoic side of the spectrum. And importantly, the majority of them will have a hypoechogenic halo around them. This is a time to throw on your color Doppler and take a look at the flow, because these will oftentimes have a perinodular, or so-called spoke wheel vascularity pattern, and I'll show that on the next slide. So here, the image on the left, this is our transverse grayscale. The image on the right is our color Doppler. You can see that sort of iso to maybe slightly hyperechoic circumscribed nodule. It has that hypoechoic halo around it. And then on color Doppler, you get that spoke wheel pattern of vascularity with perinodular increased vascularity and then some sort of streaking vascularity going through it. Now, important to keep in mind is despite what these look like on imaging, they end up getting biopsied. And unfortunately, even the pathologist can't tell you definitively that it's an adenoma unless it's completely resected and they can actually section it. They can only give you a sort of a best guess based upon a biopsy. So to confirm it, these need to come out. What do they look like on nuke studies? Well, unfortunately, they can be variable on FDG, but they may be avid. These are lesions that oftentimes are hot on I-123 or pertechnetate studies. So whenever we see a hot nodule, the vast majority of time it's benign. That's a very reassuring finding. It's really the cold nodules that we worry about having risk of malignancy. So here's an example of a thyroid adenoma. You can see on the axial contrast enhanced CT sort of this heterogeneous but maybe slightly hypodense or hypoenhancing nodule. If we look at our fused FDG PET, yeah, it looks like maybe it's a little bit FDG avid, a little bit tough to tease out from the background thyroid uptake. This is a nice area to look at your actual source PET data, and we can see unequivocally this is has FDG uptake. It's avidly taking it up. So just keep in mind, thyroid adenomas, their uptake on FDG is variable. So whenever you encounter one on a PET, anytime you're catching a nodule that's hypermetabolic like this, it's going to need an ultrasound, and then based upon its ultrasound appearance, it may or may not need a biopsy. Next up is the thyroid colloid nodule or a colloid cyst. These tend to have sharply defined margins. They tend to be largely fluid-filled. On CT, they're oftentimes low density and circumscribed. This is fairly circumscribed. It's not perfect. On MRI, these often have variable signal intensity, frequently TT bright, but it sort of depends on protein content and such. But these are non-enhancing. Ultrasound is an area that can be quite helpful as well. These are anechoic. They will show posterior acoustic enhancement, and be on the lookout for comet tail artifact. That confirms to you that it contains colloid crystal within it. So here's a colloid nodule on CT. This was path proven, circumscribed, but kind of heterogeneous in its attenuation and enhancement. So, CT, frankly, kind of sucks for trying to figure out what's going on. On ultrasound, different patient, but this is sort of a classic appearance of a colloid nodule. You can see it's anechoic, it's circumscribed. When you throw in that color Doppler, it really accentuates that comet tail artifact. Look for that artifact because that confirms that you're dealing with colloid and you're dealing with something benign. So hopefully, after me blabbering on there for the last couple of minutes, you'll realize that ultrasound really is far superior to CT and MRI in assessing the risk of malignancy with incidental thyroid nodules. I mean, CT and MRI, they just kind of suck for this. The question is, do you need to get an ultrasound every time you catch one of these on MRI or on CT? And I think we've got some pretty good data now to suggest that the answer is no. There was a nice paper published by Jenny Wong and colleagues in JACR a few years back. It's the white paper on incidental thyroid nodules, really a great example of using data to dictate how we should practice. But they were able to demonstrate that just by looking at a couple of variables, namely the age and the size of the nodule, as well as whether or not there were any other suspicious findings like extrathyroidal extension or suspicious lymph nodes that would have automatically made us suspicious. But looking at just the variables of age and size, you can actually quite nicely risk stratify these patients as far as who needs to get an ultrasound for incidentally discovered thyroid nodules on CT and MRI. This is a flow sheet from that paper. Again, you can find this in JACR. I'm not going to go through all of this just to show you it's out there. It's quite simple to go through. But I'll hit the high points of it. If there are no suspicious features, in other words, it doesn't look like this nodule has extrathyroidal invasion, it's not blowing its way out of the thyroid, if there are no suspicious lymph nodes that look like metastatic nodes, and if there are no comorbidities or limited life expectancy, which albeit is tough to figure out if you're a radiologist, But if those criteria are met, then you can look at the patient's age and the size of the nodule and figure out what needs to happen next. So if the patient is under the age of 35, and if the nodule is less than a centimeter in size, we can ignore it. If they're under the age of 35 and it's a centimeter or greater in size, they need an ultrasound. And that's simply because differentiated thyroid carcinoma is a disease that disproportionately affects younger adults, people in their in sort of that 20s and 30s age range. So we take those nodules much more seriously. Once you get over the age of 35, we get a little bit more lax in our guidelines. If a nodule is less than a centimeter and a half in size, we can ignore it. And if a nodule is 1.5 centimeters or greater, they need an ultrasound. So I think the ACR White Paper really nicely simplifies how to deal with these thyroid nodules. It's something that I've put into practice ever since reading that paper a couple years ago. And I think a lot of people have really embraced this as well. Next topic is a multinodular goiter. This is, as the name might imply, diffuse multinodular enlargement of the thyroid, and this is due to chronic TSA overstimulation. The problem with goiters is it's reported that about 5% of the time they harbor malignancy. If I ask my pathologists here at IU, they tell me they can find it virtually in all of them, given enough time, find that needle in the haystack. But again, that's because thyroid cancer oftentimes is a diagnosis that it's indolent. Not always, but oftentimes. Things about multinodular goiters that you need to know as an imager. Well, despite the fact that they are big, they tend to have defined margins, so it doesn't look like it's aggressively invading structures around it. Rather, they sort of push things away. They may or may not have internal calcifications. They may or may not have internal hemorrhage for that matter. But things that you really need to be looking for and reporting in your reports are, what's it doing to the trachea? Is it causing airway narrowing? Is it displacing it? Just how bad is that narrowing getting? Is it over a short segment or a long segment? And then also report whether or not there is retrosternal extension. So in this nice case lent to me by Rick Wiggins, you can see this ginormous goiter extending down into the mediastinum. It's important to let the surgeons know about this ahead of time, because when they go to take this out or debulk it, this goes from being an otolaryngology case to a combined otolaryngology and cardiothoracic case because of the mediastinal extent that needs to be dealt with. All right, let's talk about thyroid malignancy. As you can see on this slide, there are multiple different types of thyroid cancer. We're going to start with talking about the differentiated thyroid carcinoma. Okay, so differentiated thyroid carcinoma, the vast majority are going to be papillary. Number 2 would be follicular. This is more common in women than in men. It's about 3-to-1 ratio. And as I said before, this is a disease that disproportionately affects younger adults. You certainly can get it in older adults, but it has a high incidence in young adults, peak age somewhere in the 3rd and 4th decades. And that, again, is sort of what drives the ACR's white paper on how to deal with incidental thyroid nodules. The primary tumor oftentimes is solid, but it can have cystic components, or it can be mixed solid and cystic. Not infrequently, it has calcification. You can see this yellow arrow is sort of pointing at that fine curvilinear calcification. But interestingly, the lymph nodes, the metastatic nodes in the neck, look a lot like the primary tumor. Not always, but oftentimes they do. And you can sort of appreciate that with sort of these mixed solid and cystic lymph nodes here denoted by the yellow arrows. If you do MRI, oftentimes these will be T1 bright. That's because with differentiated thyroid carcinoma, it's so well differentiated that the nodal metastases are in fact churning out thyroid proteins like thyroglobulin. And those nodes may also have calcification within them as well. Here's a patient that has papillary thyroid carcinoma. You can see this sort of hypoattenuating or hypoenhancing infiltrating mass on the left side of the thyroid. It does look like it's invading some of the surrounding soft tissues. And you can see there are some stippled calcifications within it as well, denoted here by the yellow arrow. And as we look, there is this sort of cystic peering visceral space or Delphian or level 6 lymph node. And importantly, look at that node. This is a T1 pre-contrast image. It's pretty bright. And that's probably because of the fact that this thing has so much protein content because it's churning out thyroid proteins. Here's our fused axial fluorine 18 FDG PET CT, and you can see just how hypermetabolic that node is. So, things that I think are helpful clues when you're dealing with papillary thyroid carcinoma: look for an invasive mass or a potentially invasive mass. Look for microcalcifications. Keep in mind that those nodal metastases oftentimes look quite a lot like the primary tumor, may have microcalcifications within them, may be T1 bright due to the fact that it's churning out thyroglobulin or other thyroid proteins. Here's another patient that has papillary thyroid carcinoma, and in this case, we have this cystic appearing right retropharyngeal lymph node. Okay, it's sort of oval, certainly enlarged, no doubt about it, sitting sort of between the pharyngeal mucosal space, which is seen more medially, in between the carotid space, which is sort of getting displaced posterolaterally by it. So we look at our FDG PET CT. It's not metabolic at all. I mean, there's no FDG uptake. So when you see that, it's benign, right? Don't worry about it. Wrong. That's absolutely wrong. This is one of the critical things to recognize about cystic or necrotic lymph nodes. They are still metastatic lymph nodes, but in order to have FDG uptake, you have to have at least a base level of solid tumor component within it. And when something gets very cystic or very necrotic, it can drive down that FDG signal. So when you see that, it does need to get biopsied. And so how do you biopsy this? This is one that I did a transfacial approach under CT guidance. It looks a little barbaric, but this is honestly a very safe approach, and it's tolerated well by the patients. And so just find a safe window that you can put the needle in, obviously avoiding putting it through the carotid artery because that is certainly poor form. But whenever you biopsy these, you may not get a lot of cells, but instead make sure they're running a thyroglobulin washout on it, because if it contains thyroglobulin, you know you're dealing with a metastatic node. So a classic pitfall that we see not infrequently with papillary thyroid carcinoma: look for those cystic retropharyngeal nodes, or cystic nodes in general. But thyroid's bizarre. It gives nodal mets in sort of unexpected places. Retropharyngeal lymph nodes, even though they're sort of geographically removed, that's a nodal station that can be involved. So when you see a cystic retropharyngeal lymph node, think about differentiated thyroid cancer. These cystic nodes, again, are oftentimes cold on FDG PET. It's incumbent upon you as the radiologist to suggest that that may be what's going on. And this is where you can add value, add service by offering to put a needle into it. One more interesting papillary thyroid carcinoma case. This was a patient who had known papillary thyroid carcinoma, had previously been resected, but they had an increasing thyroglobulin level. We have our axial conventional CT on the left. You can see this node here, it's not really all that enlarged, but maybe it looks ever so slightly more dense compared to its contralateral counterpart with the red arrow. This is an area where you can use dual energy or spectral CT and play off of the physics. Use those low mono KEV sequences, sort of get down as low as you can toward the K edge of iodine, and that's going to bring up your signal. So here we can see that right-sided lymph node is really, really bright whenever we are using this mono KEV 40 sequence here, and then compare that to the contralateral normal lymph node, which is not as bright. So that tells us that node on the right side is taking up more iodine. And we can even prove that by doing an iodine subtraction map. That's the pathologic node there, denoted by the yellow arrow. We can see how it has a signal void where it's dropping out the iodine. Compare that to the contralateral normal lymph node that doesn't. This was a path-proven, non-enlarged metastatic lymph node that we can see really using spectral CT or dual energy CT. You could accomplish the same thing to look for those lymph nodes that contain increased iodine in patients with differentiated thyroid carcinoma. Here's just one example of a follicular thyroid carcinoma. Again, it's another subset of differentiated thyroid carcinoma. This I'm showing you just to drive home the point that sometimes the primary tumor is quite small and quite, relatively benign looking. Just a small little nodule on the right side, giant nodal conglomerate on the right as well. Sort of has a similar appearance, though, to the primary tumor. But big nodes, tiny primary. Thyroid cancer sometimes does that. It's a weird bird. It does weird things. Like I said, It gives you nodes in places that you don't necessarily expect it to. But importantly, sometimes the primary tumor doesn't look that impressive compared to the nodal disease. Next up is medullary thyroid carcinoma. This is a rare neuroendocrine carcinoma of the thyroid. This arises from the parafollicular C cells. These are the cells that produce calcitonin. Therefore, our serum marker in this case is calcitonin. So for differentiated thyroid carcinoma, we use thyroglobulin as our serum marker. For medullary thyroid carcinoma, we use calcitonin as one of our primary serum markers. These tend to be heterogeneous masses, but usually they're fairly circumscribed. In this case, nicely shows just how circumscribed this right lobe thyroid mass is. They may or may not have calcification. In comparison to differentiated thyroid carcinoma, the nodal metastases are more commonly solid. It's not a perfect paradigm. You certainly can get solid nodes with differentiated. You can get, sort of cystic or necrotic looking nodes from medullary, but in general, they're more solid with medullary thyroid carcinoma than with differentiated. This is also an area, because it's a neuroendocrine carcinoma, in which some of the fancy nuclear medicine agents may play a role, things like dotatate or MIBG. And I really think DOTA, at least at our shop, and I know at a lot of academic centers, has really sort of supplanted MIBG just because of the fact you can get such nice images with DOTA. So here's a patient with a medullary thyroid carcinoma, sort of a heterogeneous nodule on the right. You can see the image on the right is our fused axial PET CT image. You can see that this one was FDG avid. Just keep in mind that the degree of FDG avidity can be quite variable with medullary thyroid carcinoma. This is a patient who has medullary thyroid carcinoma. We can see the image on the left, the axial contrast CT component. There's sort of a little nodule on the patient's left side, not super impressive on CT imaging. Here's our fused gallium-68 DOTA scan. You can see, it does have a little bit of asymmetric increased DOTA uptake. Those with eagle eyes in the audience might recognize, oh, that's not good. We have a lymph node, not an enlarged lymph node, but we do have a left level 5B node back here that is also DOTA avid. And so this is a patient who had medullary thyroid carcinoma with nodal metastases. Next is anaplastic thyroid carcinoma, and this is truly a lethal tumor. If you carry this diagnosis, you're stage 4 disease at baseline. This can arise from differentiated thyroid carcinoma that sort of breaks bad and gets really bad. And what does it look like on imaging? It's ugly. I mean, there's no other way to describe it. These are large, they're heterogeneous masses, they're invasive, infiltrating. You can see this is taking up the entirety of the left lobe of the thyroid. It's invading out into the surrounding structures as well. These patients commonly have nodal and even distant metastatic disease. Because we don't use radioiodine to treat these patients, iodine load is not a consideration, so it's fine to do a contrast-enhanced CT. This is another patient with anaplastic thyroid carcinoma. You can see this really ugly right thyroid mass. It's partially necrotic. It's invading out into the surrounding soft tissues. And speaking of those surrounding soft tissues, you can see it's invaded the internal jugular vein, which has a long segment of internal thrombus. You can also get metastases to the thyroid. Clinically, these are thought to be uncommon, but perhaps they're a bit under-recognized. The problem with it is the imaging findings are truly and utterly nonspecific. There's no way I can look at this and tell you on the CT that this is a metastasis rather than it being a thyroid primary malignancy. And it really runs a gamut. These can be small defined nodules to a large infiltrating mass like this. The common culprits are simply the common culprits. The ones that are more prone to be seen and to be seen with advanced disease, such as breast, kidney, colon, lung, melanoma, the usual suspects here. And I would say probably the best advice here would be use your clues. If they have a known cancer, they've got a rapidly enlarging thyroid mass, they have known systemic mets elsewhere, it should be on the radar, but at the end of the day, you're going to have to biopsy it to get the answer. This is a patient that had a large left lobe thyroid metastatic lesion. I think if I remember right, the history here was renal cell carcinoma. You can see where the yellow arrow is pointing, sort of an ugly left lobe thyroid mass. Could, for all the world, have been an anaplastic thyroid carcinoma. But in this case, biopsy demonstrated that it was metastatic disease. Sort of an interesting feature in this case was there was also in the same slice, you could see this lytic bone lesion. If you do some Hounsfield measurements, you can see it's similar to the thyroid. But again, that doesn't really tell you that it is a met to the thyroid. It very well could have been a thyroid cancer with a bone met. You just have to put a needle in it to know. Next up is thyroid lymphoma. Most commonly, this is going to be a diffuse large B-cell lymphoma. Important take-home point, this has a high association with chronic lymphocytic thyroiditis. In fact, it's thought somewhere on the order of a 70 times lifetime risk of developing non-Hodgkin lymphoma in patients who have lymphocytic thyroiditis or Hashimoto thyroiditis. Now, these patients do, however, tend to have pretty good survivals unless there is extrathyroidal extension of tumor. What does it look like on imaging? Well, as this coronal CT shows, these tend to be fairly homogeneous, relatively low density, and importantly, this is a non-surgical disease unless there's airway compromise, in which case they will do thyroidectomies because of the fact that you can't compromise the airway long enough to let the chemotherapy do its effect. Protecting the airway is really critical. So again, dealing with a thyroid lymphoma, you can see it's diffusely enlarged, maybe asymmetric to the left, largely low density. This one's even creeping its way down to the mediastinum. And again, typically these are not surgical cases unless there is urgent airway compromise. I can't talk about thyroid lymphoma without talking a little bit about chronic lymphocytic or Hashimoto thyroiditis. In this disease, patients have anti-thyroid autoantibodies, and that's really how you make the diagnosis. They need to check those serological labs. But as I said before, we're talking about coexistence with non-Hodgkin lymphoma, maybe setting these patients up to a 70 times increased risk. Ultrasound is really our modality of choice here. Early on, you'll see diffuse enlargement of the thyroid, tends to be hypoechoic and hypervascular. Is it absolutely specific? No, you can get a similar appearance with Graves' disease or subacute thyroiditis, but suffice to say, this is the general imaging appearance, enlarged, hypoechoic, and hypervascular. In the late stage, when it starts to burn out, the thyroid gets small and hyperechoic. And the CT findings really parallel this as well. Early on in the disease process, the thyroid tends to be diffusely enlarged and relatively low density. Later in the disease process, it becomes atrophic and maybe a little bit hyperdense. Here's a nice case on ultrasound of what it looks like. You can see diffuse enlargement of the thyroid on the grayscale image. It's very hypoechoic, and then you put on your color Doppler and look how vascular this is. So that's a good look for chronic lymphocytic thyroiditis. The imaging is suggestive. You need the serology to confirm it. Next topic is acute suppurative thyroiditis. And this is quite a rare diagnosis, and that's because the thyroid is typically pretty resistant to infection because it's an encapsulated organ that makes it harder to infect, and it has its own preservative in it. It contains high iodine content, which is bactericidal. Typically, this is found on the patient's left side due to an underlying fourth brachial cleft anomaly. I'll talk about that here in a minute. But it's not always the case. But most commonly, it's going to be found on the left side. These are not always going to be associated with that fourth brachial cleft anomaly, but that is really the biggest predisposing feature. Just like everything else we've talked about with the thyroid, ultrasound is really our first-line modality. This is a nice case lent to me by Jim Milburn down at Ochsner. And you can see this thyroid is effectively a pus pocket. It's hypoechoic. There's some posterior acoustic enhancement. It's enlarged and thickened. And ultrasound can give you the answers and tell you, yeah, it looks like we've got a big, boggy, fluid-filled thyroid bed. But importantly, it's also the tool by which you can put a needle into it and aspirate the pus, sending for diagnosis and culture and all the important things that are helpful for figuring out the treatment profile and which antibiotics need to be used. Can you use CT? Sure. CT is a helpful tool. It's probably better than ultrasound in some ways for looking for extrathyroidal extension and better defining the extent of infection and inflammation in the neck. But thyroid ultrasound really is kind of our first-line modality in these patients. So this is the same patient. Again, thanks to Jim Milburn for lending me the case. And you can see the entirety of the thyroid bed is hypodense, hypoenhancing. But this, interestingly enough, was asymmetric to the right. And as I told you before, the fourth brachial cleft anomaly, those are virtually always, to my knowledge, always on the left side. I've never seen a right-sided one. If someone's got one, please share it with me. I'd love to see it. So this one, probably not due to an underlying fourth brachial cleft anomaly. Diabetics, immunocompromised patients, patients with direct penetrating trauma certainly can get acute suppurative thyroiditis without having the underlying predisposing congenital lesion to set them up for it. So I talked about it enough already, but let's show you what it looks like. This is that fourth brachial cleft anomaly. Again, a congenital lesion. Typically, this is going to present in a child or a young adult. And these are virtually always, or honestly, to my knowledge, these are always on the left side. I've never seen one on the right side. I've never seen one in a textbook or a journal article on the right side. I'm sure someone's got a case, and if you've got it, please share it with me. I'd love to see it. But what does it look like on imaging? Well, look for the associated things like suppurative thyroiditis. I just showed you what that looked like on ultrasound and CT. You may or may not have a true intrathyroid or perithyroidal abscess. But then also look for this piriform sinus fistula. So in this nice diagram, you can see that where this dotted line is at, there's an actual fistulous tract connecting the apex of the piriform sinus down to the thyroid bed. And that's what sets you up to have that spread of infection from the aerodigestive tract down into the thyroid bed in the left anterior neck. So what does it look like on imaging? This is a case that was given to me quite a handful of years ago now by Rick Harnsberger when I was putting together a talk for a conference. And this is a patient that has a fourth brachial cleft anomaly with a thyroid abscess. And so here, the image on the left, the axial CT image, we're at the level of the piriform sinus. So you can see all that inflammation and thickening and enhancement around it. The coronal image, you can see that there's that sort of multilocular abscess within the left thyroid bed. And then look carefully where the yellow arrow is pointing at now, and you can see the opening to that fistula going from the piriform sinus all the way down to the thyroid bed. This is another patient that had a fourth brachial cleft anomaly and developed a thyroid and perithyroidal abscess. I'm just showing you this to show you the value of doing an esophagram or a barium swallow. You can actually see where that yellow arrow is pointing at, contrast egressing into that fistulous tract. And here in the left lower neck, we can see this fluid and gas pocket where the patient had a brewing abscess. Now, the most common congenital neck lesion that we encounter is a thyroglossal duct cyst. These have sort of a bell-shaped distribution where 25% of the time they're found in the suprahyoid neck, and in the suprahyoid neck they're found at midline. About half the time they're found at and around the level of the hyoid bone. And then the other fourth of the time, they're found in the infrahyoid neck. And when they're in the infrahyoid neck, they sort of fan out paramidline, sort of following the expected location of the thyroid lobe. So again, in the suprahyoid neck, you find these at midline, going from the foramen cecum at the base of the tongue all the way down to the hyoid bone. And in the infrahyoid neck, these are paramidline in location. These look like simple cysts unless they're infected or inflamed. So here's an example, just sort of your standard issue thyroglossal duct cyst. It's midline. It's sort of just in the immediate infrahyoid location, sort of embedded between the strap musculature. This one on this contrast enhanced CT just looks like a benign non-inflamed cyst. This one is in a patient, similar location, just in the immediate infrahyoid neck. But this patient had a antecedent upper respiratory tract infection, and because these can sort of have that conduit connecting back to the base of tongue, and because of their embryologic origin and development, these can get inflamed with upper respiratory tract infections. And so when you see sort of this rim of enhancement around it, it may be either infected or inflamed because of a recent infection. Does that mean that it's cancer because it has this enhancing rim around it? No, it doesn't. Could it be cancer? Well, maybe. We'll talk about that momentarily. So, thyroglossal duct cyst carcinoma is a critically important thing that head and neck imagers be aware of. And this is a malignant tumor that arises from a thyroglossal duct cyst. Unfortunately, these are rare. We're talking about probably less than 2% of thyroglossal duct cyst eventually, if given the full natural history, would break bad and become a thyroglossal duct cyst carcinoma. The vast majority, probably more than 95% of the time, these are going to be papillary thyroid carcinoma. So differentiated thyroid cancer is your prime actor here. Much less commonly, we'll see squamous cell carcinoma. What do you want to look for on imaging? What's your tip-off that tells you that you should be worried? Well, you want to be looking for solid components, and in particular, you really want to be looking for calcification. So, when you see soft tissue within a thyroglossal duct cyst, it is a nonspecific finding. It may be the sequelae of prior infection or inflammation, or it may be cancer. The imaging has low specificity. Whenever you see calcification, that is always concerning for cancer. Let me say that one more time. If you see calcification within a thyroglossal duct cyst, that is always concerning for cancer. So here's a patient that had a thyroglossal duct cyst carcinoma. We see sort of this large, almost bilobed appearing infrahyoid neck cystic lesion, the cystic mass, denoted here by the yellow arrow. You'll notice there's some frond-like soft tissue component to it. That gets us a little suspicious. Maybe it's prior inflammation, but that frond-like appearance looks kind of papillary. But pay close attention. We actually see stippled calcification within this. And so this is one I biopsied. This is path-proven papillary thyroid carcinoma. Next, we'll talk a little bit about the parathyroid. And really, the hallmark lesion to know about here is a parathyroid adenoma. This is a benign neoplasm. It does secrete parathormone, so these patients will have elevated calcium or elevated free calcium levels. When we image these with Tec-99 sestamib, you see early uptake, and it sort of stays late. You can combine that with SPECT CT to have a much more sensitive evaluation as well. We also like to do dynamic or multi-phase CT imaging, so looking at this in the non-contrast, the arterial, and the venous washout phases. And that's because classically, these are reported to have rapid arterial enhancement and venous washout, but it doesn't always follow the rules. I've talked to some people at other places. There's been some papers published on this as well. It's variable. I feel like where I work, only a minority of these have that true classic rapid wash-in, wash-out enhancement characteristic. But, depending on where you practice at, maybe that's a higher number. But there are the important take-home point is they don't always have that classic appearance. So here's one that does have that classic appearance. We can see in the left tracheoesophageal groove, we have, on this non-contrast phase, we have a subtle nodule. It enhances like gangbusters during the arterial phase, and it washes out during the venous phase. So this is that classic appearance, rapid arterial enhancement and washout during the venous phase. This is the textbook version of what a parathyroid adenoma looks like. Again, the problem being they don't always look like this. Is there a role for MRI? Well, here's one that was found incidentally on just a routine contrast CT of the neck. So this is sort of the venous phase. Pretty subtle, right? I mean, I don't know how it was I picked this up, other than things looked a little full back here. But there was this sort of this nodular thickening. Honestly, wasn't sure if I was dealing with a parathyroid adenoma or an enlarged lymph node, or whether or not this was just some funny look to the prevertebral musculature. And so recommended an MRI. And you can see very T-tube right. That's commonly seen in parathyroid adenomas. And yes, it is enhancing. So MRI is sometimes helpful for identifying or troubleshooting CT when dealing with parathyroid adenomas or potential parathyroid adenomas. And here's just a totally oddball case. In this case, we have a fused sestamib SPECT CT. It looks like there's some increased uptake sort of sitting back behind the thyroid. You look at the imaging, we have sort of this low-density circumscribed mass that if you put Hounsfield units on it, there are certain spots within it that contain true fat density. So this was a sort of a lipid-rich parathyroid adenoma or a lipoadenoma. So sometimes these parathyroid adenomas are low density and cystic. Sometimes they're even lower density and fatty. They don't always hyper-enhance, so don't be fooled, okay? They can have a variable imaging appearance. If you really dogmatically follow the rules of, it has to rapidly enhance the arterial phase and then wash out during the venous phase, you're going to miss some of these, okay? You're probably going to miss a significant number of them. But whenever they have that history of an elevated parathormone and elevated free calcium levels, you really need to be looking exhaustively until you find one. You can also have cancer involving the parathyroid, so parathyroid carcinoma. This is a low-grade malignancy by the WHO. Usually these are quite large, 2 to 3 centimeters in size is pretty common. And unfortunately, these are oftentimes indistinguishable from parathyroid adenomas. And the only way that you can tell definitively on imaging is if you see invasion of adjacent structures. So these are all going to get surgical resection, but your job is really to look for that those things for staging, like what's it invading. So here we again see this sort of low density mass in the visceral space, really indistinguishable from the prevertebral musculature and the esophagus. So this is a place where MRI can be complementary in trying to better evaluate the extent of tumor. And so in this case, you can sort of get a better sense of where it's extending and where we have still preserved tissue planes on the T1 pre-contrast imaging. Here's another patient with a parathyroid lesion, thought based upon its size and its appearance that this very well could be a parathyroid carcinoma. You can see on CT, sort of low density, kind of has that infiltrating, almost invasive look to it, and it was markedly bright on sestamibi. So this came out, and I thought that the actual path note, which had sort of a some caveats to it, really was helpful for my better understanding these tumors. So, and that's why I want to share these with you. So, based upon the 2017 WHO classification of endocrine tumors, in order to make a pathologic diagnosis of a parathyroid carcinoma, you have to have some things. You have to be able to see and demonstrate some things, and those things all have to do with invasion of surrounding soft tissues. So you want to be able to, you have to be able, I shouldn't say you want, in order to make this diagnosis, you have to see presence of extracapsular blood vessel or perineural invasion, or invasion into the adjacent structures, and that would include the surrounding soft tissues or the thyroid, or you have to have documented metastases. And even the pathologist can't make all of those calls. And so this is one where the pathologist actually said correlate clinically. I mean, that's not just a radiology thing. So importantly, you need to be looking for where these are going and what they are doing and what they are getting into, because you literally cannot make the diagnosis of a parathyroid carcinoma unless you can show invasion or metastases. So the last structure to talk about in the visceral space is and it contains the level 6 lymph nodes, which are subdivided into a paratracheal group, which is important because this is the first order nodal drainage of the thyroid, and it's how you get spread of thyroid cancer down into the mediastinum. There's also a prelaryngeal and pretracheal group as well. Okay, so that was the visceral space. Now we're going to talk about the carotid space, and each of these will be quicker than the last one. Just so much stuff happens in the visceral space. All right, carotid space. I'm not atherosclerosis and dissection and pseudoaneurysm. That's like a separate vascular talk altogether. I want to focus on just a few things. And first of all, talk about typic syndrome versus vasculitis. So what is typic syndrome? This stands for transient perivascular inflammation of the carotid. This is what used to be called carotidemia. In fact, StatDX for some reason still calls this carotidemia, even though the international headache community for like the last 14 years has said, please stop calling it this. Carotidemia, that's a term we should throw away. So I've been trying to get our residents, our fellows, our faculty to stop using the term carotidemia and instead favoring the terminology typic syndrome, because that's really what's considered to be the standard working definition now. But this is a disorder of idiopathic inflammation. Don't know what causes it, but these patients will oftentimes present with tenderness, swelling, or even a pulsatile mass in the neck. What does it look like on imaging? On CT, you can see, denoted here by the yellow arrow, we have circumferential but eccentric wall thickening along the carotid. and it's usually not flow limiting. If you look at the caliber of this involved right carotid artery, it's no different than the contralateral side. So despite the fact that you have this perivascular inflammation, the soft tissue component, typically it doesn't narrow the luminal caliber. What does it look like on MRI? Well, it tends to be T-tube right. If you give contrast, like in this case, it tends to enhance pretty avidly. And typically this is going to involve the carotid bulbs and extend up into the proximal internal carotid arteries as well. This is a disorder that gets treated fairly conservatively. They hit these patients with NSAIDs and sometimes steroids and then repeat imaging just to make sure it's going away, because this is a self-limited disease process. The problem is it can look very similar to something that's a bit more heinous and needs more aggressive management. And that's large vessel vasculitis. So large vessel vasculitis can really look a lot like Tippich syndrome. And some of the ones that can do this, because it's a large vessel vasculitis, you'd be thinking about Takayasu in a younger patient or giant cell arteritis in an older patient. But because the stakes are so high, because the consequences can be devastating if that doesn't get treated appropriately, it probably is worth at least considering getting these patients plugged in to see a rheumatologist. Even if you think it's high likelihood of Tippich syndrome, they probably need to get followed. And I think rheumatology may be the best person to at least get the ball rolling on it. I don't know. It's not well established, but at least they are the ones that can run point if it does turn out to be a vasculitis. So here we can see sort of this soft tissue along the carotid bifurcation as well, and something that looked an awful lot like Tippich syndrome. Same patient. When we look on the axial CT, well, interestingly, this was bilateral, and this was extending really up and down the common carotid artery and not just the internal carotid artery. And so, sort of saying, well, maybe this is Tippich, maybe it's just sort of an odd presentation, but then take a closer look. Whenever you see something like this, make sure to hawk all the vessels. Look down at the aortic arch and the takeoffs of the great vessels. God, we have that same sort of low-density wall thickening. This was a patient who had Takayasu arteritis, and so it's just exert some caution whenever you see one of these before you just blow it off as being Tippich or carotidynia, if you're going to use that bad terminology. But probably should be making sure that you're not dealing with a large vessel vasculitis is a lesson that I've kind of learned over time. All right, next is jugular vein thrombosis. This is quite simply clot forming in the jug. Certainly is not uncommon. We see it all the time. Usually these are straightforward diagnoses, and the challenges lie not in making the diagnosis, but rather trying to figure out what the etiology was that caused it, and then to look for any associated pathologies and any associated complications. Most commonly, we see this in ill patients that may have an implanted cardiac pacemaker, a defibrillator, or an indwelling catheter. Those are the patients who typically have these, but not the only patients. What does it look like on imaging? You look for an intraluminal filling defect within the jugular vein itself. In the acute phase, that oftentimes dilates up the caliber of the vessel, so it's an enlarged diameter. You may have engorgement of the vasovasorum. So if you look where this yellow arrow is pointing, it almost looks like a donut sign of increased density along the vessel wall. That's because those vessels that supply the vessel wall, the vasa vasorum, they're engorged with blood. And in the chronic phase, it tends to shrink down and you get a small caliber vessel. In the acute phase, we more commonly see perivascular edema, denoted here by the yellow arrow. And almost immediately, you'll see bypass collateral starting to crop up because there's so much redundancy in the venous system that if you clot off one, blood is going to figure out a way to get back to the heart. The problem we oftentimes, I shouldn't say oftentimes, the problem that we sometimes get into is, what do you do with enhancing clot? So enhancing thrombus is problematic. And so here you can see the yellow arrow is pointing to an area within the clot that's a little bit higher density, and at the poles, the upper and lower pole, it's lower density thrombus with the red arrows. And it may be something benign like organizing thrombus, and we're starting to detect some of those recanalization channels. Or, unfortunately, it could also be tumor thrombus. And so differentiating those two can sometimes be a bit challenging. You may have to rely on multimodality imaging or short interval follow-up. Certainly, if you have a mass in the neck or the upper chest that's growing into the jug, well, then maybe you have your... But this was a patient who had jugular vein thrombosis. You can see on the left, on the contrasting at CT, it's non-opacified, but at the image, you can see that FDG uptake. All right, next we'll talk about nerve sheath tumor. These are going to be schwannomas or neurofibromas. I mean, I suppose I could throw in malignant peripheral nerve sheath tumor as well. But with the benign nerve sheath tumors, we're dealing with circumscribed and fusiform masses. They can look quite similar. Sometimes neurofibromas are lower density on CT, more common to have a true target sign to them because they grow sort of throughout the nerve. They grow centrally within the nerve rather than schwannomas that grow eccentric to the nerve. There is a lot written about and talked about with displacement patterns that can help you to predict the nerve of origin. So if you're dealing with a vagus nerve schwannoma or neurofibroma, it's thought to push the internal carotid artery anteromedially and push the posterior cervical space posterolaterally. That's in contradistinction to a sympathetic trunk schwannoma or neurofibroma that tend to push the ICA and IJV together as one, like in this case is showing. You know, I don't know how much stock I put into that. You can certainly go through the mental gymnastics, and I think it's not a bad idea to talk about and let the surgeons know what you think the nerve of origin is. That's probably wise. Just know it's not perfect, and you're not going to have great predictive value in being absolutely certain that that's the nerve of origin. Lastly, I want to say just a few words about lymph nodes along the carotid space. So there are no true carotid space lymph nodes, okay? But they're nodes, they're not contained within it. They run along it. They're affiliated with it. So the internal jugular nodal chain is in close proximity to the superficial margin of the carotid space. And therefore, they can exert mass effect upon the carotid space. And if you have extranodal extension of tumor, like squames in the neck that sometimes do that, or thyroid carcinoma with nodal mets, they can blow outside of the nodal capsule. That can invade the carotid space, and that can set the patient up to bad consequences like arterial rupture and exsanguination, or even vagal neuropathy. So I'm not going to say much more about lymph nodes. Just know that the internal jugular chain lymph nodes live along the carotid space. They're not truly contained within it. And when they act badly, when they're poorly behaved, there can be consequences for the carotid space structures. All right, the next space to talk about is the retropharyngeal and danger space. And these are sort of the pathologies that can involve it, at least the common. And we'll start out talking about infection because that's really sort of a primary thing that we oftentimes are trying to deal with. So that infection can be phlegmon, or it can be a Okay, so how do we draw this distinction between retropharyngeal phlegmon and abscess? And really it has to do with looking for loculation in that rind of enhancement, that rim of enhancement that's forming. So this image on the left, you can see there's a lot of fluid within the retropharyngeal space. It's also sort of extending out into the other deep spaces of the neck. Here we can see it in the retropharyngeal danger space, but we don't see any rim enhancement. So that's phlegmon. The image on the right, you can see fluid in the retropharyngeal danger space, but it's also starting to develop a rind of enhancement around it in a patient who has a true abscess. Next up is the goiter. Talked about goiters before, so I'm not going to belabor the point. Just know that they can sort of curve their way up and extend up along the retropharyngeal space. So when goiters get big, we absolutely and quite frequently see retropharyngeal extension. So here you can see just an example of that. I don't want to belabor this point. Next up are this is simply an uncommon location of a common tumor. And you know what lipomas look like. These look like lipomas elsewhere. They're fat density. They're T1 bright. If you use fat saturation or stir, they're going to null and signal. They're circumscribed. They're non-enhancing. And here we can see just sort of this almost lens shape appearance, this benign circumscribed retropharyngeal lipoma. It's T1 bright. Same patient, just looking in different planes. You can see how nicely circumscribed this is. It's just sort of insinuating between the structures. It's not invading anything. It's T1 bright. The image on the right, you can see that it's fat density. Easy peasy. It's a lipoma. Next topic is the medialized carotid artery. This is just a normal anatomic variant, okay? This is just when that carotid artery has more of a medialized course. It sort of pooches its way into the retropharyngeal space. This is not a pathologic finding whatsoever, but it's important because you want to let the surgeons know about this on preoperative exams if they're going to be doing a surgery involving the pharynx or the larynx. They're going to be getting down to this region, even a discectomy and fusion. You want to let them know about this, okay? Just to make it safe for the patient. We can also have ectopic parathyroid glands involving the retropharyngeal. The parathyroid glands usually sit posterior to the thyroid, so here we have a nice example of that. And their embryologic descent of the inferior parathyroid extends along the thymopharyngeal duct tract, and that really goes from the angle of the mandible above down to the anterior mediastinum below. So sort of encompassed within that, one of the places where you can on rare occasion find ectopic parathyroid tissue is truly within the retropharyngeal space, so it's just something to include in your search pattern. All right, the last space I'm going to talk about is the posterior cervical space. I'm not going to talk about the perivertebral space because that's sort of a topic in and of itself as well. But there are just a few things to be thinking about with the posterior cervical space. First of all is lymph nodes. So this is where we find our spinal accessory chain nodes, or level 5 lymph nodes, and they can come in a lot of flavors and they can wear a lot of hats, right? They can be reactive lymph nodes. You can have suppurative lymph nodes. I kind of talked a little bit about that when I was talking about abscesses. You can have metastatic nodes of head and neck primary or systemic primary as well. And you can have lymphoma nodes. So each of those sort of has a little bit of a different look to them. And this is not a lymph node talk. That's another thing to maybe in the future I'll put together to share with you. But I really just want to stress, be looking for lymph nodes in the posterior cervical space. That should be in your nodal search pattern. This was a patient who had so-called signal nodes or a Virchow node. I know classically it's taught that a Virchow or signal node needs to be on the left side, but guess what? You can have them on the right as well. So whenever I see a cluster of sort of necrotic nodes like this, isolated just right supraclavicular right level 5B or left supraclavicular left level 5B, really be thinking about systemic metastases from a chest or breast or lung or gut, some other spot in the head and neck. Yes, of course, you want to search all of your nodal stations in the neck when you see this, but if it's isolated just to this, be thinking about systemic malignancy, and that's exactly what this patient had. This was colon cancer, if I remember right. Next, you can have lipomas involving the posterior cervical space, and that's simply because the main constituent feature or contents of the posterior cervical space is fat. And so you can have lipomas live there. Here's a lipoma, fat density on the left, it's T2 bright on the right. This was not a fat-saturated sequence, therefore it's still bright. If it was fat-saturated, it would drop out. You know what they look like. You can also get nerve sheath tumors occurring here. And this is simply a relatively uncommon site of a common mass. It may be a schwannoma or a neurofibroma. They look like nerve sheath tumors elsewhere. They're circumscribed, they're fusiform in shape. Much more commonly to be sporadic than syndromic, although if you start seeing multiple, do think about syndromes like NF1 for neurofibromas or NF2 or schwannomatosis if they're schwannomas. And keep in mind, after the brachial plexus dives out from between the scalene musculature, it courses through the posterior cervical space. So these may be nerve sheath tumors arising from the brachial plexus. This is a patient with multiple neurofibromas. You can see on the coronal stir image, some of them are quite bright. The one on the patient's left or on the right side of the image that the yellow arrow is pointing to has sort of that target sign. And these enhance avidly, but maybe a little heterogeneously for some of them. So multiple, be thinking about syndromic. This was an NF1 patient. This patient had a brachial plexus schwannoma. You can see it's sort of pooching out from between the anterior and middle scalene muscle group into the posterior cervical space. It's circumscribed, it's heterogeneously T2 bright. Nice look for a schwannoma. A couple other tumors, or I should say a tumor and some lesions that can involve this space as well, but are by no means specific to this space, just something that can show up here, and thought this would be a good time to talk about them. First is a hemangioma. Hemangiomas are tumors, okay? They are tumors. They are vascular tumors. They are benign, but they're tumors. These are not vascular malformations. These are typically GLUT1 positive. So on histopathological assessment, they look for that. These are usually inapparent at birth, but present soon after, and they go through a proliferative phase and then usually a regression phase. There is an association with facies as well to be thinking about in newborns. And what do they look like on imaging? They tend to be avidly enhancing in T-tube right. I showed a GRE here for a reason, and that's to say there are no phlebolyths within this. So it's a large sort of GRE, therefore sort of T-tube right mass within the left posterior cervical space. But there's no phlebolyths. There's no big vessels going to this either. I'm sorry, this one we can't see the big vessels solely for contrast. This one may have big vessels, but there are no phlebolyths. In patient, here we get to the coronal stir. We can see the flow voids of the big vessels that are associated with it. It is enhancing, maybe not enhancing like gangbusters, but it is enhancing. This is a good look for a hemangioma. The critical thing to keep in mind, these are tumors, benign tumors, vascular tumors, but nonetheless tumors. These are not vascular malformations. These are not what we call hemangiomas in the spine. Don't get me ranting about that. That's a separate subject altogether. Oh, let's talk about that separate subject. Vascular malformations. These are not tumors. These are vascular malformations. These are malformative lesions of the vessels. These are defined by their slow. Are they no flow, such as a lymphatic malformation? Are they low flow, such as a venous malformation? Or are they high flow, such as an arteriovenous malformation or a dural AV fistula? Okay. This one had no enhancement. This one had no flow. This is a case lent to me by Rick Wiggins. This is a large lymphatic malformation in the posterior cervical space. The ISSVA has really done a good job of defining what these are. I think every trainee out there needs to go to the ISSVA website, just read over the nomenclature. Words matter. We need to make sure we're reporting these accurately to our referring clinicians. These are not tumors. These are vascular malformations, and as such, they can be trans or multispatial because we're dealing with a congenital lesion. This was a lymphatic venous malformation. We oftentimes in radiology throw the term veno-lymphatic malformation out there all willy-nilly. Truth be told, that is an extraordinarily rare diagnosis, okay? This one was a true lymphatic venous malformation. And we can say that because it has elements of both. So this has fluid levels on the T2 weighted image. That's a feature that we oftentimes see with lymphatic malformations. It does show true areas of enhancement. A lymphatic malformation may have some peripheral faint enhancement, and when they aggregate together like a multi-cystic kind of look, it can look like internal septal enhancement, but that's usually quite fine. Microcystic lymphatic malformations, because their little cysts are so tightly packed and so small, it can give it more of an enhancing look, but that looks different than this. This actually has splotchy enhancement that if you tracked it out through delayed phases sort of washes in. And also this has phlebolyths. So this has components of lymphatic and components of venous malformation. But again, I want to throw out there, using the term veno-lymphatic malformation, we really should be cautious of using it. True lymphatic venous malformations like this exist, but they are rare. You can see septal enhancement of macrocystic and microcystic lymphatic malformations, and when they sort of are aggregated together, that can look a little bit more enhancing, and those are incorrectly termed as veno-lymphatic malformations, and it matters for management purposes. Okay, so that was a lot of content. That was sort of a whirlwind overview of the infrahyoid neck spaces. We talked a little bit about the anatomic contents. We talked a lot about common pathologies, some don't miss lesions as well. Really some take-home points here. Know the contents of each of these anatomic spaces and try to identify the space of origin of an unknown lesion within the neck and the infrahyoid neck, because there's so much going on there. It's really critical to try to figure out where it's coming from, and that will help you to generate a succinct, appropriate differential diagnosis. So, as always, thank you so much for tuning in. I know it's a tough time right now. We're really seeing an escalation of coronavirus going on, and I know we're not the only ones. There's a lot of people around the country that are experiencing this, and to a much greater degree than we are currently, but it's a problem we're all dealing with, and hang in there. Try to stay positive, stay safe, stay healthy, stay sane, and share educational resources. If you're stuck at home in quarantine or on furlough as a resident or a fellow, this is a great opportunity to try to learn, to read textbooks. And there's a lot of great educational content out there with free open access on the internet and on social media. So continue hanging in there, and we'll all get through this eventually, and we'll get to it working together. So thank you so much for tuning in. Take care of yourselves.